All right, so today we're going to talk about blood, and we're on page 69 in the lab packet. There's the objectives go to page 70 at the top. You'll see it goes, there's objectives 1 through 13, so be sure that you remember to turn the page when you're studying for the lab exam, that there's a page and almost a half of objectives. So we're going to just first talk about what is found in blood and the different components of it, and then we'll go through each of the objectives. So blood is a connective tissue. It's the only liquid connective tissue that can flow from point to point. So if you remember from general AP, connective tissues have a plasma, or I'm sorry, they have a fluid matrix. And in the case of blood, the plasma is the fluid matrix, and then there's cells that are suspended in the fluid matrix. So the plasma is the fluid, and the cells are red blood cells and white blood cells and platelets, which are little pieces of cells. So we call those the formed elements because they are solid. That's the solid part of blood. And if we spin blood in a centrifuge, those components, those formed elements, will settle to the bottom of the tube. And we're going to actually do a little centrifuging of our blood today in lab. Or if you're online, you'll do it in a simulation. So if we look at a patient that comes in and they're not feeling well, maybe they have some underlying disease like heart failure, respiratory failure, kidney disease, pretty much all the time, or even just a young college student coming in saying they're not feeling well, they're going to do a complete blood count just to see what's going on in the blood, looking for signs of infection or something being off. So they're going to look at the red blood cells and the information that tells us how many red blood cells there are and how functional those red blood cells are is looking at hemoglobin and hematocrit. MCV and RDW are other things we measure. We're not going to talk about those in our lab. If you were taking, hematology course, you would go into that in more detail, but we're just going to hold you accountable for the hemoglobin and hematocrit. So that's going to tell us, about red blood cell production and function. And then white blood cell data is looking at the total white blood cell count. And there might be a differential. And what a differential means is that you want to look at not only what is the total white blood cell count, but specifically what are the numbers of the different white blood cells. So if you look at your objectives number 5, it gives you different percentages of the different white blood cells. So that's what a differential would provide information about is, are there elevated neutrophils versus basophils versus monocytes or lymphocytes? So they would look at specifically the different types of white blood cells and what those counts are. And then a platelet count. So let's talk about hemoglobin first. It tells us the amount of hemoglobin in our blood. We know that hemoglobin constitutes over 90% of the red blood cells, so it's a large protein. And if we see a decrease in hemoglobin, that's an indication of anemia, or if we see an increase in hemoglobin, that is something called polycythemia. But you don't need to know any disorders for today's lab. Just be aware that those disorders would throw these numbers off, but you're not going to be held accountable for the diseases. So hematocrit is expressed as a percentage. So it's the percentage of total blood volume that's made up of red blood cells. So what we do is we spin the blood to separate the red blood cells from the plasma, and then we measure the height of that column to figure out what the hematocrit is. So the taller the column, the more red blood cells. So here's an example of a capillary tube that's been spun, and we can look at the height of this red blood cell column. And the higher the column, the more red blood cells, right? So we know that plasma makes up about 55% of whole blood. So a normal hematocrit in an adult male versus female, 40 to 54 for males, females a little bit less, 37 to 47. So men have more red blood cells than women do in their blood. So you would just look at the height of this column as how that's measured compared to the total amount of blood and plasma in the column. So it's expressed as a percentage. And then hemoglobin is expressed as grams of hemoglobin in a deciliter of blood. So that's a special measurement. We don't have the tools to measure that here. But again, if I see a low column, a low hematocrit, then that's an indication of anemia. So you have a low percentage of red blood cells. And it's not uncommon for college-age women to have anemia, just as something that just kind of happens with women. And most of the time it's due to low iron stores. Sometimes that can be a result of heavy bleeding, menstrual bleeding, or just being low in iron just because the iron or the liver doesn't do as good of a job at storing iron. So sometimes women need an iron supplement. So it's important for a woman to know what her blood count is and what her ferritin level is, because that's how we store iron. It's kind of a carrier for iron in the blood, and some women have normal hemoglobin and hematocrit but have low ferritin, and sometimes they can even benefit from a little iron supplementation, because we know that low iron causes fatigue. So if you or someone you know has chronic fatigue, maybe bruises kind of easily, maybe has heavy menstrual flow, might be worth supplementing with some iron, but always talking to a doctor before they do that. Okay, looking at total white blood cells then. If we see an increase in white blood cell count, so if you look at objective number 3, letter B for leukocytes, we should have between 5 and 10,000 white blood cells per microliter of blood. So anything more than that is a sign of infection or leukemia. Leukemia means white blood, which means white blood cells are growing out of control in the bone marrow and then are released to the blood, and they don't function properly, so they're dysfunctional white blood cells. So people with leukemia have bone pain because of the increased number of white blood cells being produced in the bone, and they bruise easily because they have dysfunctional red blood cells, because the red blood cells are crowded out by the abnormal cancerous white blood cells, and they're prone to infection, and they have fevers because of an abnormal immune system, because those white blood cells are just growing out of control, just multiplying, dividing out of control. Or they have active infection, so that would be another reason why you might see that number being greater than 10,000. If it's less than 5,000, so the range for white blood cells is 5 to 10,000, and if it's less than that, we call that leukopenia. Leukopenia. So if a person has an immune disorder where they're not able to fight off infection, like in the case of AIDS, where the number of T cells goes down because of the HIV infection, that would cause leukopenia. Or chemotherapy. You know, when you're targeting cells, you're trying to cure leukemia, you're going to kill the healthy white blood cells along with the cancerous ones. And that's why people that come in, you know, sometime into the hospital is because they have really low white blood cell counts and they need really close monitoring, especially kids that are getting chemotherapy. Kids get a slight fever and get an infection with a low white blood cell count. It can take their life within 24 hours if we don't respond. So that's why when adults have cancer, they get their chemotherapy outpatient. But if a child needs chemotherapy, they usually stay in the hospital for the duration of the treatment because they're so sensitive to infection that can take their life. So when I worked on pediatrics for a while, I saw that we had kids there. One girl was there for like 6 months. And it's their life and it's their culture. And when it's time to discharge because you're healthy, do you think they're happy to go? No. Because the body adapts, the brain adapts, and those kids would really have a hard time separating from all the nurses and going back to just their home with their dog and maybe a parent and a sibling and, you know, not all the interesting environment of the hospital and the visitors and all the positive people around them. It's a big, big adjustment. Okay, so a differential again is when we separate out, so we know the total white blood cell count, let's say it's greater than 10,000. Now we want to know what percent is neutrophils and lymphocytes. So if we look at neutrophils, if you look at the percentages in objective number 5, you'll see that those are the largest amount. So those are the highest in number. And then come the lymphocytes, and then the monocytes, then the eosinophils, and the basophils. So I listed them here according to their prevalence in the blood. So you can see that neutrophils are the most numerous of the white blood cells. And we also see those very high during bacterial infection. So as nurses, when we look into that differential white blood cell count, we see high neutrophils, we're thinking bacterial infection. If they have a high number of lymphocytes, so B cells, T cells, or lymphocytes, then we know we're looking at potential viral infections. We tend to see higher lymphocyte counts with viral infections. Eosinophils and basophils are higher when someone has allergies. Eosinophils also are higher when someone has a parasitic worm infection. Monocytes are sometimes higher in people with mononucleosis, but there's other white blood cells that are elevated as well. So platelets, sometimes people have increased number of platelets because of just dehydration, less plasma, so they have more platelets per cubic milliliter. So just dehydration can throw off all these numbers. But some people, when they come in for a heart attack or stroke or even a major hip or shoulder or knee surgery, they're given a medicine called heparin to thin their blood and prevent blood clots. Some people have a reaction to heparin and it destroys their platelets. It's called heparin-induced thrombocytopenia. And anytime you see penia, think low numbers, low numbers. So neutropenia means low numbers of neutrophils. They're very much prone to infection if they have low neutrophils. Thrombocyte are the platelets. Penia means low number of platelets. I just took care of a lady 2 weeks ago that had thrombocytopenia. Okay, so here's a CBC that was taken in a lab, and this is in the chart, and we can look at this and say, see, again, in the chart, they're always going to have high and low for you, so you can see what's normal or abnormal. So if I look at these numbers here, does this person have any abnormal values that we should be concerned about? Nope. And again, we don't have to, analyze these, but the numbers are in your packet on number 5 for the differential. But this would be a differential here, right? Because it's telling us the different percentages of the different white blood cells. And if you look and compare those two are normal. So this is a normal CBC. Again, it stands for complete blood count, CBC, complete blood count. And again, with differential or without differential. So this is with differential because it says differential. Some are manual or automated. Automated means a machine counts them out, and manual means you actually have a lab tech looking through the microscope and counting those and evaluating the numbers. So how about this one? This one is not a differential. What do we see? High white blood count. Anything else? Low hemoglobin. Would we expect to see hemoglobin and hematocrit both be low together? Red blood cells, right, contain hemoglobin, so if one is low, the other is also going to be low in most cases. And how about the platelets? Yeah. So this person has a couple of terms we could say. They have leukocytosis. Leukocytosis means high white blood cells. So leukocytosis, because you have a 19.5 for the white blood cell. The red blood cell count is low, so we would say anemia. Hemoglobin is low, hematocrit is low, so some type of anemia is occurring here. Because if you look at number 9 in your objectives, you have to know some of these terms. And the platelet count is also low. So what would we call that with a platelet count of 98? So we have anemia, we have leukocytosis, and in reference to the platelets, thrombocytopenia. Okay, so those are some terms that we would apply to this individual that has these readings. All right, so let's go back and just look at, again, plasma, constituents of plasma. So 55% is plasma, found on the top of our tube here. And then we have erythrocytes are about 45% on the bottom, and the small little white is where those white blood cells are. It's less than 1%. So if we look at plasma in and of itself, it's a sticky, opaque. What is opaque? Oh, this is just blood. I'm sorry. This is just blood in and of itself. So blood is sticky. Opaque means you can't see through it, right? It's solid red, has a slightly metallic taste. The color varies. If it's very dark red, that means it's low in oxygen. Bright red means it's high in oxygen. pH is 7.35 to 7.45. It's about 8% of our total body weight is blood. Average volume, 5 to 6 liters for males, 4 to 5 liters for females. So again, they have more blood per volume than, or for their body mass than women do. Okay, so here's where we talk about water. In your lab packet, it says 92% water. Our textbook says 90% water, so either one is acceptable. 90 to 92% is close enough. And in that plasma are lots of dissolved solutes, but it's really important stuff. So it's mostly water, but that 8 to 10% that is dissolved stuff, the solutes, are essential to life and survival. And that's why we donate plasma, right, to help people that are missing some of those constituents in the plasma. So plasma proteins are proteins that are floating around in the plasma. So that, remember, plasma is extracellular fluid, right? So these are proteins that were produced by the body, and now they're dissolved in the plasma doing their function, you know, they have a specific function. So albumin is the largest component of these plasma proteins. This is important for keeping fluid in our vessels because water follows solute, right? We talked about that last week. So the more dissolved substances I have in the plasma, the more water is drawn to that area because osmosis goes from high water to low water concentrated, or from dilute to more concentrated areas. So the more solute, the more that's going to pull water in. So albumin holds water in our blood vessels, and albumin is produced by the liver. So if a person has liver failure, they have poor albumin production, they have low solute in their plasma, and fluid leaks out of their vessels into their tissues. And what do we call that when we have excess fluid in the tissues? Edema. So that's what we would see in someone that has liver failure and low albumin. So what do we give them? We give them albumin in a small little bag via IV. We can give them directly that particular plasma protein, and that would be for a falling blood pressure. Sometimes the elderly, their liver is fine. I mean, in terms of they didn't damage it with, you know, disease or, you know, unhealthy lifestyles like drinking or drug use, but they just are old. Sometimes they need albumin just to keep their blood pressure up. So we'll give them albumin to pull that fluid back into the vessels and out of the tissues. Globulins are for white blood cells. The lymphocytes produce antibodies, and those antibodies are proteins. So we find antibodies, any antigen or any foreign thing that you were exposed to in your lifetime, you produce an antibody to it, and that is found in your plasma. We'll talk about the blood type antibodies today. And fibrinogen, this is necessary for blood clotting. So 4% is fibrinogen, but it's dissolved in the plasma. Not until this clotting factor, this clotting cascade begins, do we see fibrinogen convert to fibrin. And it requires some chemicals given by a broken blood vessel and by the blood itself that starts this clotting cascade, where you end up with fibrinogen turning to fibrin, which is a solid in the blood, which plugs a vessel, plugs a hole in a broken blood vessel. So hopefully you talked about that in general A&P a little bit. Fibrinogen turning to fibrin should sound familiar. But anyway, blood clotting is the purpose of it. So here is just kind of a list from your textbook of the different components of plasma and what its function is. Because if you look at your objective number 6, it says list the major constituents of plasma, know their percentages, and know their functional role. So again, not a lot, it's not very difficult to remember. Most of it is water, so 90 to 92% is water. 7% are the plasma proteins, and the other 1% are, again, really important, even though it's a small percentage, nutrients. Like, what would the nutrients be? Everything we absorb from our digestive tract, right? Glucose, carbohydrates, amino acids, fatty acids, all the stuff we talked about with the organic chemistry in the metabolism unit. So everything that you've absorbed from your digestive tract has gone through the hepatic portal vein, is going back into the blood, right? Through the vein, hepatic vein. That's going to contain the nutrients that we need, that our cells are going to absorb all over the body. So that's important. The respiratory gases we talked about last week, what are those two gases? Yep, our oxygen, carbon dioxide. Metabolites, those are just breakdown products of things that maybe medicines we've taken. They're broken down for metabolism. Vitamins, hormones, we talked about the endocrine system. All those hormones are found in the plasma. And the electrolytes. Key electrolytes are magnesium, phosphorus, calcium, sodium, potassium. Those are some of the big ones that you're going to see that you're going to need to replace as people become ill and come in. The most common one is potassium we see with the elderly because they're taking a blood pressure medicine and a diuretic. And typically those diuretics are hard on potassium. They turn on the kidneys to help them pee away excess fluid, keeping their blood pressure down. But at the same time, those kidneys dump off potassium as well, potassium that was supposed to stay in the body. So if they're not eating a high potassium diet, or at least trying to get a little extra potassium, they end up with low potassium when they come in, and we need to replace that. So that's just that 1%, but really, really important stuff. All right. So when we look at these in a cell, or I'm sorry, in a slide, some things you need to keep a watch for is red blood cells are very small. They're the most numerous in the slide, and they have no nucleus or any organelles. So when you look at a slide of blood, you're going to see a lot of red blood cells with pale centers. They don't have a nucleus. And then you're going to see all these other larger cells with kind of oddly shaped nuclei. Those are the white blood cells. And then these fragments of cells, those are the platelets. So think of a plate. When you drop it, it breaks up into little pieces. That's where platelet comes from, that name. So you have to identify the different white blood cells. And we could have you do a CBC, you know, where we have you count the number of white blood cells in a sample. But because I don't think anybody is in this class going into our medical lab tech program, so I'm going to save that for the medical lab tech to talk about. What you're going to be looking at are numbers in the chart primarily. So we're just going to focus on having you at least identify what these white blood cells look like, but we're not going to do a CBC. Okay, so we talked about hemoglobin, you know, grams per 100 mils of blood. Talked about that. Anemia, just information. But if we look at a slide of blood, the red blood cells should be nice and round, small, pale centers, pretty uniform in appearance though, wouldn't you say? If you look at all of them, don't they all look about the same size, shape? Yeah. These are unique because they're, you know, different white blood cells. But so let's look at example of sickle cell anemia. There's something wrong with the hemoglobin S. There's we talked about that a little bit when we did the genetics unit in lab. Remember that there was a mutation that caused a change in an amino acid, one amino acid, and it changed the shape of hemoglobin. So when oxygen levels get low, the red blood cells turn from this nice round, kind of small, flattened in the middle cell to the sickle cell shaped, which is like a C shape. And as a result, instead of going filing through one at a time through the smallest of capillaries, they start to clump up because they don't have that round kind of resilient shape. They just clump up with this thin C-shaped structure, and I'll show you a picture. And as a result, oh, it's not till the end. Okay, we'll wait on that. But as a result, they get a lot of blood clotting. So whenever they're in a low oxygen environment is when people with sickle cell anemia start to have symptoms. And when you think about sickle cell anemia, think of clotting. So what would cause low oxygen environments for a person with sickle cell anemia? They could be sitting right here in the classroom and have a sickling event. What would cause that? You could be fine sitting next to them and they're having a sickling event because they're having oxygen issues. What would be some individual oxygen issues? Yeah, exactly. Asthma, emphysema, pneumonia, lung cancer, anything that would cause diffusion, some upset of the respiratory membrane, right, is going to cause low oxygen. And as a result of the low oxygen condition in the body, hypoxia, their blood cells sickle, and now they've got major clotting issues. Or let's say they want to go to a wedding to someone out in Vail, Colorado. Could that cause problems for them with the high altitude? Yeah, that would be sickling. Or how about heavy exercise? You know, they thought they were in shape and they end up running extra distance or something was extra hard, or maybe they're working in the backyard, low oxygen, sickling crisis. And these people end up in the hospital needing blood transfusions because of all the clotting. So if someone's having a sickle problem, do you want to let their legs dangle off the edge of the bed if they're having clotting issues? No, you want to elevate their extremities, right? This is in the nursing program, and I think one of them was even on the NCLEX. So sickle cell anemia, you don't want to have dependent, like hanging down limbs, because they're going to clot. You want to keep the blood flow to those tissues. You elevate. Okay, so that's sickle cell anemia. Leukocytosis, we talked about. Anything over 10,000 is what your lab book says. Your textbook says 11,000, so 10 to 11,000 is acceptable for answers. And the names of the different of the different white blood cells are easy to remember if you say never let monkeys eat bananas. So neutrophil, lymphocyte, monocyte, eosinophil, and basophil. So never let monkeys eat bananas. So this just gives an example what a differential. So there's that 1% of the white blood cells split out into the different white blood cells for a differential. So a neutrophil, you should know what these look like. You do have to recognize the different white blood cells. So a neutrophil has a multi-lobed nucleus. That's the key thing. And they have little dots in the cytoplasm, which we call granules. So look for the multi-lobed nucleus, so greater than 2 lobes. Eosinophil has red cytoplasm, so that's really characteristic, and they have a bilobed nucleus. Kind of looks like an alien face there. But look for the red cytoplasm. It's the only one that's characteristically red. Basophils have a bilobed nucleus, if you can see through it, but they have really big, dark granules. So look for the large, dark granules that pretty much crowd out the nucleus and the cytoplasm. You can't see any clear cytoplasm because it's full of these big dark granules. Lymphocytes are pretty small. If you compare the size of this cell to the red blood cells around it, it's only about 1.5 times bigger. That's key to thinking about lymphocytes. Lymphocytes have a single large round nucleus, but you can see a little cytoplasm peeking out here, so it's not a basophil. Some people confuse basophils with lymphocytes. Just be cognizant of the fact that it has some cytoplasm visible. And again, the size is 1.5 times bigger. If I compare the basophil to the red blood cell here, can you see how much bigger it is? Yeah, so the lymphocyte is much smaller. It's the smallest of the white blood cells. And then the monocyte is really big. It's the biggest of the white blood cells. It's almost 3 to 4 times bigger than a red blood cell, and it has a kidney bean shaped or bilobe nucleus. So look for that large, really large cell with the kidney bean shaped nucleus. Okay, so again, some terms. Leukopenia would be low white blood cell count. Again, maybe chemotherapy. Leukemia, talked about that. So here's a slide of sickle cell anemia. Can you see the funny shaped red blood cells? They're kind of flattened C-shaped structures. So that's definitely sickle cell anemia. So next lab exam, you might see a slide and he'll say, what is the condition? You know, is this normal, abnormal? If it's abnormal, what is the condition? So know that this is sickle cell anemia. And we're always going to see, you know, a white blood cell or 2 scattered in that slide. That's normal because we know the white blood cells make up a small percentage of our whole blood, you know, 1%. So we're going to see 1 or 2 maybe. But if you look at this slide, there's way too many white blood cells, right? These cells with, and you know they're the white blood cells because they have a nucleus, because again, red blood cells don't have a nucleus. So we can see many, many different types of white blood cells in here, and this is an example of leukemia. So that's what that would look like if someone came in and needed a blood test and they wanted a differential. They could determine how many of each kind, but just looking at this, we can see there's way too many white blood cells. Questions on that? All right, then this just kind of shows you a little bit about the function and where they're formed. All these are formed in the bone marrow. Red and white blood cells are formed in the bone marrow. Then they're released to the blood, and they have a lifespan. So if you look at how long these live, you know, they're not around for very long before they need to be replaced. And the bone marrow's job is to do that, is to replace them. Okay, so the next part of lab is looking at blood groups, and you're going to test your blood, and I have a simulator to test blood for online students in mastering A and P, so they'll do that check there. But there's 4 different major blood types in the human population, and they're based on the antigens, these little take that back, on these self proteins that are on the surface of your red blood cells, and you were born with those. So here we look at the 4 different blood types, AB, B, A, and O. On this person who's type AB, it tells us what are the antigens, what are the proteins bound to the surface of their red blood cells. And they were born with these, okay? So we're born with our blood type. We inherit these blood cells with the specific proteins bound to them from our parents. It's written in our DNA that we inherit from the chromosomes at fertilization when we were formed. So a person that's type AB has the A antigen on their red blood cells, and it has the B antigen on their red blood cell. So as a result, those are self, right? Everybody would agree with that? They inherited that. Their red blood cells have A and they have B. So when this person is developing their immune system in the early, infant period, in the first year, even sooner than that, they're not going to form antibodies to themselves, right? We form antibodies to things that we're not born with, things that are foreign to us. So if we inherit blood cells with A and B antigen, we're not going to have any antibodies against these 2 antigens. Would you agree? Because there's only 2 antigens that we focus on. There's over 30 actual antigens, but there's only 2 that we focus on when we look at blood typing. It's the A or the B antigen. And then there's also the Rh, which we call the D antigen. But this chart doesn't talk about that. So let's just focus on A and B for right now. So a person that's type AB has A and B antigen on their red blood cells. They're not going to have any antibodies to A or B in the plasma. Remember, that's where the antibodies are, is in the plasma, because they were born with A and B. That's not foreign to them. But if they're blood type B, the type of antigen they inherited on their red blood cells is B antigen. So what other antigen is out there? A, right? There's only 2 antigens that we're focusing on right now, A or B. So if you're born with B, are you going to recognize A if it came into your system? No. So if it comes into your system, you're going to form antibodies to it. And you're going to have A antibodies if we look in your plasma, because that's foreign to you. And how do we get exposed to these antigens? We don't know exactly. We think it might be bacteria that enters in from the environment. It might be the food we eat early in life that brings these antigens in. There's a bunch of theories of how the antigens come into our body. But either way, we're not born with them. We're exposed to them and we form an antibody because it's foreign. So if you're type B, A is foreign to you. Does that make sense? Okay, if I'm type A, I have A antigen on my red blood cells, so therefore B is going to be foreign, and if I'm exposed to it, I'm going to form antibodies. So if I look in the plasma of someone who's type B, I'm going to find A antibodies, because that's foreign to them. And if I'm type O, that means I have no, so just think the 2 rhyme, O, no antigens on the red blood cell. So if I'm exposed to A or B, am I going to recognize that? No, I'm going to form antibodies to them because they're foreign to me. So if I look in the plasma of someone who's type O, they have A and B antibodies, but no antigen on their red blood cells. So can you see why type O would be a universal donor? They can give to anybody? Because look at those red blood cells. They're clean as a bean. No one's going to react to them. So everybody wants the O blood types to donate because they've got, nice clean red blood cells. We can give to anybody, universal donor. But who can they receive from? Only O, because what do they have in their plasma that's going to cause problems is the A and B antibodies, right? Which is going to attack any red blood cell that has either A or B antigen on it. And when antibodies attack, they cause clumping. They cause what we call agglutinations. So Rh is another type of antigen, and if they receive Rh in blood, we're going to form anti-Rh antibodies. So if we have a mom who's Rh negative, but that baby inherited dad's chromosome for blood type, and the baby is Rh positive, sometimes during childbirth, baby and blood plasma and mom's blood and plasma mix, and mom is going to be exposed and she's going to form antibodies against Rh. Then early in the or in her second pregnancy, she could again have that mixing of her antibodies and baby's red blood cells, and that would cause major clumping of the baby's red blood cells, and that can cause death. So what we do to mothers when we know they're Rh negative is we give them a shot of like a medicine, I guess. It's called Rogam, and what it does is that the mother forms, or the antibodies bind the Rogam instead of baby, and then that protects the baby from transfusion, or I'm sorry, a blood reaction between mother's plasma and baby's red blood cells. Okay, so what happens, it's called Erythroblastosis Fetalis. So it happens in the fetus, and again, something we want to avoid, so we always make sure right when we find out whether it's their first or second pregnancy that they get that Rogam. So it contains the antibodies.
So did you say the Rogam, the mom's antibodies bind to the Rogam instead of?
That's the question. Whoops, that's the question that I. So I'll try to explain the Rogam reaction a little better at the end of the video. Okay, so what we get is a transfusion reaction, that if somebody would accidentally hang the wrong blood for a patient and that blood type doesn't match. And there are so many checks in the hospital that this rarely happens. I mean, we double check, and you have to have 2 nurses to hang a bag of blood. And you have to do so many verifying before you actually open the tubing to let the blood run in, that it's very cautiously approached, that we don't want any errors. But it has happened. There was a huge humanitarian effort in the 80s of a girl from Mexico that was brought here to get a heart transplant. She was 15. The heart transplant was successful, and somebody hung the wrong bag of blood toward the end of the surgery, and she died from it. So what a shame. To do advanced heart transplant, and then we just mismatch blood and screw that up, and she died from it. So that was a long time ago, and again, there's a lot of checks that happen in the hospital, but we still need to be aware. Sometimes because there's other antigens other than A and B and Rh, sometimes you can have the blood well matched, but this person has had so many blood transfusions that they just become sensitive, and they develop things you look for is fever, change in heart rate or blood pressure, because we're always looking at that in the first 15 minutes of delivering blood, or just, a change in any vital signs or discomfort described by the patient. What's the first thing you would do if you start to see signs of a transfusion reaction? It's another test for the test question for the NCLEX. Nope, before you even do that. They're having a reaction. What's the first thing you do? Stop the infusion. That's the answer. Don't forget that. You'll thank me when you get to the nursing program. I remember that. Stop the infusion. Yes, because sometimes you get all willy-nilly that we forget to stop the infusion that's causing the problem, right? So that's what you would do. So here's an example. So you have type A. We know B antibodies are in the plasma, so we already talked about that. But here, let's say we have B antigen gets exposed to B antibodies. So you've got a type A blood type, for example, right? They would have B antibodies in the plasma, and then you give them type B blood. Those antibodies attack and clump those red blood cells. So we call that an agglutination reaction. You have to know that term, agglutination. And that's just a clumping of red blood cells. And then because they're clumped, then they lyse, so the plasma membranes break down, and we call that hemolysis. So all the contents of the red blood cells then spill out into the plasma, and all you have are fragments of red blood cells. So there's no way there's any oxygen carrying ability here. So there's clotting and low oxygen, and those patients will quickly die if we don't fix it. So some symptoms of a reaction, like I said, fever, chills, changes in blood pressure, heart rate, nausea, vomiting. And we want to make sure that we, like someone else said, give them fluids. That's definitely correct. to flush it out, flush out all that hemoglobin from the burst red blood cells, right? So that is true, we would do that, but that's not the first thing you would do. Okay, so we know that type O is a universal donor. Type AB can receive from anybody because they don't have any antibodies, right? Because they have A antigen on their red blood cells and B antigen, so they don't form any antibodies. They can get from anybody. So if you want to pick which is the best blood type to be, it would be blood type AB, wouldn't it? So when we want to figure out what your blood type is, what we're going to do today is we want to take a patient's blood and, well, we would mix the patient's serum, which is their plasma without the proteins in it. That's what serum is. It's just plasma without any of those albumin and fibrinogen. And then we mix it with some red blood cells from the donor. And if it clumps, we know the antibodies in that serum clumped with the red blood cells of the donor, and that would not be a match, right? We want to make sure there's no clumping. So then we know we're ready to go. So here's an example. So if I take, well, this is what you're going to do today. If we put a drop of blood, you're going to put 2 drops of blood on your slide. Actually 3, because we're going to test you for Rh also. We call that antibody D. So you're going to put 3 drops of blood on your slide. And then if I add serum that contains antibodies in it, so that's what anti-A means. Anti-A means I added antibody A to this blood. Did it clump? This is what no clumping looks like. This is what clumping looks like. So this is no clumping. We can just see a nice even liquid of blood. So this is clumping and this is clumping. So if I added, so what I added here was antibody A. It clumped. So that means the antibodies bonded to the antigen on the red blood cell, the A antigen, and caused them to clump. Here I saw clumping as well. When I added the antibody B for my little bottle on my drop of blood, it clumped. So this person is type AB because they had a reaction to antibody A and antibody B when I added it to their blood. Now we would never do this in the body of a patient, right? This is always outside the body that we do this testing, this matching. So, because if we are driving in an ambulance and working as a paramedic or an EMT and someone's on the side of the road bleeding out, what do we give them? Type O and O negative, because it doesn't have Rh either. That person, if that person's Rh negative, they're going to have Rh antibodies and then they would react to that. So we give them O negative. 1% of the population is O negative. And they can donate to 99% or more of the population. So we should really like encourage and recruit the O negatives to come and donate. Anybody in here know that they're O negative? Oh, look at that. So you guys, we should pay you to come in and donate your good blood. I can't personally, but we should do good things, like at least feed you well when you come, you know. Give you a personal ride, maybe a limo ride to the donation centers. But here, this person is type A. So we know they have A antigen on their red blood cells. So when I add serum with A antibodies in it, it's going to clump. But I know that they have, if they're type A and they have A antigen on their red blood cells, if I add antibody B, we know that's not going to react because there's no B antigen because they're type A. So just keep in mind that the blood type that you are tells us what's on your red blood cells. Okay, so type A, A antigen on the red blood cell. And the other letter is what you have in your plasma as an antibody that's going to clump if it comes in contact with that, right? So if I'm type A, I'm going to clump with B, right? If I'm type B, I'm going to clump with A. If I'm type AB, I'm not going to clump with anybody. If I'm type O, I'm going to clump with everybody. Make sense? That's kind of just a quick way to summarize these. And that's what we see. Does type O clump with either? Nope. Type B clumps with A. Type A, what, did I say that wrong? No, sorry. Type B clumps with B. Type A clumps with A. All right, so questions on that? Then let's go to our worksheet and go through the answers on there. So the first four you're going to fill out yourself. And if you're not doing anything in lab, if you're an online student, then you would just put the normal values in there. Or if you know what you are, you can put those numbers in there. But you can just skip that first part or make something up. For number 1, the normal range for hematocrit for males is what? 40 to 54, and for females? 37 to 47. So the hematocrit above is, oh, that would be if you tested yours. Yeah, so you can just say normal. The normal values for hemoglobin is, for males is 14 to 18, and for females 12 to 16 grams per deciliter. Little d, big L. Grams per deciliter. And you can look at your hemoglobin, and if you're online, just say normal for now. So number 3, sample of hemoglobin was found to have a level of 10 grams per deciliter. What was the hematocrit? So what we find is that if we know the hemoglobin, the hematocrit is 3 times larger than that, and it's expressed as a percentage. So what would the hematocrit be if we have a hemoglobin of 10? 30%. Yep, 30%. So consider the blood type group above. Do we have a blood type group?
I think that's us, or test.
Okay, well let's use an example here just so we have something to work off of. All right, so let's look at this slide together. So this, we put a drop of their blood on the A, the B, and the RH. And then we added A antibodies to this one. Did it clump? Nope. We added A antibodies to this. Did it clump? No. We added B antibodies to this one. Did it clump? Yes. So that means B antibodies are only going to clump B antigen on red blood cells, right? So we know these red blood cells contain B antigen. Do they contain A antigen? No clumping. RH antigen? No clumping. So what is the blood type of this person? B negative would be the blood type of this person. So what antigens, for number 4A, what antigens are present on the red blood cells? B, and that would be it. But don't fill this out for those of you that are in class, because this is only for the online students. This is just an example. I just want you to be able to answer these, put this off to the side if you want. Draw a little picture off to the side of your paper so you know how we answered these, so you can apply your own blood type to it. So what antibodies are expected in this person's plasma? Anti-A and anti-D, correct. Because we know they have B antigen. They're not going to make antibodies to themselves, right? So they're going to have everything but what we see clumping. So A and RH are anti-D. So anti-A and anti-D. What other antibodies could develop, if any? None. What blood type could they safely receive if a blood transfusion was needed? So we said they're B negative. So they can't have anything that has what? Do they recognize A if they're B negative? Do they recognize RH or D? No. So can they have A positive?
No.
Right, A positive. The positive, right, is the D, right? And the A is foreign. So no. Can they do A negative? No. Can they do B positive? No, because that positive is going to react, right? Because they do not have D or RH on their red blood cells. B negative?
Yes.
Yes, they can have B negative. Type AB positive? AB negative? Nope. Type O positive? Nope. Type O negative?
Yes.
Yes. They could have that because that does not have the RH factor in it. Okay, so there is a backside. The group data, you can skip that if you're an online student. Number 7, column A. Plasma membrane protein A, B, and D. What do we call those? You can call them antigens or another GEN word, agglutinogen, letter I, and definitely know these terms. So these lab worksheets are something you should be studying prior to taking your lab exam. So be sure you're using these. That's why I make you, turn them in for points. Even though it's only 2 points, it just is a way for me to show you these are important. Okay, term for a clumping reaction. Yep, agglutination, letter F. Percent of formed elements, red blood cells. It's expressed as a percent. Remember which one that was? Hematocrit, letter B. The relative distribution of various leukocytes or white blood cells, what do we call that? Differential count, letter J. Plasma protein with a role in clot formation, Fibrinogen E. Number 6. Neoplasia. Neoplasia means new growth. Yes, leukemia, white blood cells. And when you ever think neoplasia, think cancer. Abnormally high white blood cell count. Leukocytosis, letter K. Abnormally low hemoglobin level. D, anemia. And things that would cause low hemoglobin, I think it's in your PowerPoint too. We've talked about anemia. Other things would be blood loss. We see that a lot on the floor I work on. People have had cardiovascular surgery. They've had bypass surgery. There's a lot of blood loss as a result of that. So we always see low hemoglobin levels. We see them typically somewhere between 8 and 9. And we just kind of let that go, and slowly but surely the body adjusts and kicks out some more red blood cells, and they're okay by the time they discharge. But sometimes not. Then we need to give them blood. And that's the treatment for that, is giving them blood. It's just a small little bag. It's a very thin, square bag of blood. So when we say blood transfusion, before I got into healthcare, I thought of blood transfusion with these big tubes and this big machine, and there's this, big elaborate setup. It's not. It's just they sit in their room, you hang a little bag of blood on the line with some saline, and you run it in. And it's pretty, not very exciting. But it's very serious. I mean, like I said, we do a lot of checks and we watch for reactions and things. But it's amazing how the patient's cheeks will pink up after they get some blood. It's just amazing how quickly that benefits them, and they feel so much better. Okay, responsible for osmotic pressure of blood, number 9. Albumin, correct. Letter H. And number 10, anti-A and anti-B antibody. What do we call those? Agglutinins. Agglutinins. So those are antibodies. All right, in 1 microliter of blood, what would we expect to find in terms of erythrocytes? How many should we see in 1 microliter? Bless you.
Thank you.
Yep, 4.2 to 6.2 times 10 to the 6th. And the number of leukocytes, a normal value is 5,000 or 10,000. And thrombocytes, we should expect to see 250 to 400,000. And then matching up the percentages. Eosinophils. Now, remember I said if you arrange it, never let monkeys eat bananas. That's the percentages from increasing to decreasing order. So eosinophil is what percent? 3%? Yep. Monocytes? C, 6%. Basophils? D, 1%. Neutrophils? A 65%, that's the most numerous, and lymphocytes, B 25%. So when you think lymphocytes, think like B cells and T cells. We'll learn about that when we study the immune system coming up during Thanksgiving week. But that's what lymphocytes are, those B cells and T cells. So number 10, there's another question there. It says a female patient's lab report listed white blood cell of 13,000, hematocrit 42%, hemoglobin 13, and then the following differential. What does she have? What's going on here? What are the terms that we could say about that?
Elevated white blood cells.
Yep, so what do we call that condition? Yeah, very good. Leukocytosis. And look at her differential. Which of those numbers is higher than it should be of those white blood cells? Yeah, the neutrophils. So when we have high number of neutrophils, we call it neutrophilia. But you don't have to know that term. I don't think that was on your list, was it? But what do we say a high neutrophil count usually indicates?
Bacterial.
Yeah, bacterial infection. So it shows some type of bacterial infection. We see patients, you know, they cut themselves out in the yard and they don't take care of it right away and they end up with a serious staph infection that enters the blood and then they need IV antibiotics. So it's very, very important that when you cut yourself that you put something on it right away so you don't get infection entering the blood.